All right. Good morning and welcome to the Tracking Healthcare Disparities in Iowa session of the Iowa Ideas Conference. I'm your moderator, Sofia DeMartino. This session is within the Diversity, Equity, and Inclusion track of the conference. Our time together will include talking with our panelists and addressing some audience questions as well, so please feel free to submit those questions. All of our sessions have closed captioning access, and all of our sessions are being recorded. At this point, I would like to take a moment to thank our sponsors of the DEI track. Those are the University of Iowa Healthcare and Inclusive ICR. Please stand by for a brief message from our sponsors.
Welcome to the Iowa Ideas Conference. I am Kimberly Hunter, Interim CEO and Interim Associate Vice President of the University of Iowa Hospitals and Clinics. The COVID pandemic brought about exceptional challenges, such as worker shortages and healthcare disparities that really have changed the way we view healthcare. However, it has also highlighted opportunities for innovation and improvement. For example, we have seen a move towards telehealth, which helps us provide better access to care for all Iowans. We know that healthcare excellence is achieved through innovation and collaboration. And that is why we are a proud sponsor of this conference, and we are excited to hear your big ideas on how we can come together to improve quality of life and quality of care in Iowa. On behalf of the University of Iowa Healthcare, we hope you enjoy the conversations, make some great new connections, and leave inspired to help us shape the future of healthcare. Thank you.
Hi friends, Angelica Vanetta, co-chair of Inclusive ICR. We are a coalition of over 220 employers in Eastern Iowa, all working together to grow the diversity and inclusion of our workforce, to create a space where employees feel a sense of belonging, included, and valued. Inclusive ICR is a proud sponsor of the Diversity, Equity, and Inclusion track of the Iowa Ideas Conference. As you participate today, be sure to connect with other Inclusive ICR champions, as we'd love to share information with you about our upcoming coalition meetings, projects, and how our work is impacting positive social change in our region. Be sure to check out our website at inclusivicr.org for upcoming events and our e-newsletter. Thank you and have a great conference.
Thank you. All right, we'll go ahead and get started. So the CDC defines healthcare disparities as preventable differences in the burden of disease, injury, violence, or opportunities to achieve optimal health that are experienced by socially disadvantaged populations. Healthcare disparities negatively impact members of the LGBT community, Black, Indigenous, and other people of color, persons living in poverty, persons who are unhoused, and more. In fact, the United States has among the largest income-based health disparities in the world. The CDC goes on to describe healthcare disparities as inequitable and directly related to the historical and current unequal distribution of social, political, economic, and environmental resources. Now, Iowa is not immune to this issue. Disparities persist and result in a long list of abysmal outcomes, including shorter lifespans, higher maternal mortality rates, and lack of access to care. I would like to give our panelists an opportunity to introduce themselves and give a brief introduction of the topic from their perspective. We will begin with Ann Carter from Linn County Public Health. Ann?
Thank you, Sophia, and good morning to all of you who are tuning in and perhaps watching this on a later broadcast at some point in the future. I have the privilege of serving as the Health Equity Program Manager at Linn County Public Health, and this is a newly created role. It was newly created when I stepped into it last April, and I share that because I'm brand new to public health, and perhaps like many of you, I didn't give public health a whole lot of thought before the COVID pandemic started. And now I have a whole new appreciation for what it means to manage population health, and, if you will, the distinction between healthcare and public health. And I promise I'm not going to geek out on you too much today, but I do look forward to highlighting some of the opportunities and really significant gaps that we have right here in the state of Iowa. So thanks again for joining us.
Thank you, Anne. Next, we have Max Mowitz.
There, my name is Max, my pronouns are they and he, and I am the program director at One Iowa. We are the statewide LGBTQ advocacy organization serving all 99 counties in Iowa. And for us, health equity is deeply intersectional because we work with LGBTQ individuals, but LGBTQ individuals also share many other backgrounds and experiences and intersecting identities. So one of the things we prioritize in our work is paying attention to the way that LGBTQ identities impact health equity, and making sure that we're trying to meet some of those or bridge some of those gaps and dismantle some of those barriers in the work that we do. It's really baked into the work that we do and who we are at One Iowa generally. Health and wellness is one of our guiding principles. So I'm really excited to be here and chat more about this topic.
Thank you, Max. Now we have Mary Charlton.
Hi, I'm an associate professor in the Department of Epidemiology at the University of Iowa College of Public Health. I'm also the PI and director of our Iowa statewide cancer registry, which tracks, in theory, 100% of cancer cases diagnosed among Iowans, and a lot of data associated with that. I'm also co-leader of the Cancer Epidemiology and Population Science program at the University of Iowa Holden Comprehensive Cancer Center, and I'm the newly elected president of the Iowa Cancer Consortium, which is leads our state's cancer control plan. And also on the American Cancer Society Iowa State Leadership Board. So kind of a one-hit wonder of all cancer all the time, but in the organizations I work with, we collect a lot of data that allow people and organizations to really identify disparities and then track progress based on programs and policies designed to address those disparities. So we feel like we have a really big role in doing that. And we definitely have identified disparities in Iowa that until looking at the data, I wouldn't have believed, but we actually have one of the highest Black cancer mortality rates in all of the country, and right here in Iowa and right in our neighbors around us. So there's a lot of work to be done.
Thank you, Mary. And rounding out our team, we have Henny Orr.
Hi, my name is Henny Orr. I am a co-founder and director of EMBARC. We are a grassroots refugee community-led organization. We believe in change that starts from the ground up, and our model is based on a train the trainer, peer-to-peer social learning model. I appreciate being on this panel and being with all of you.
Thank you. All right, for the group, how is your organization working to collect data, and what barriers exist that make this work more challenging?
I guess I can start off since my organization, our whole role is to collect data. So we're always trying to figure out the kinds of data that it would take to better identify and address cancer disparities. Some challenges to that is, we collect data from the 118 hospitals across Iowa. And if you think about things like race, ethnicity, sexual orientation, gender identity, things like that, they're collected in 118 different ways, it feels like, in all the different hospitals and clinics also throughout Iowa. And we really try to prioritize, what is the self-reported data? Where does that end up in the medical record? How can we get everybody to collect the best data from the best spots in some sort of consistent manner so that we can do a lot more reporting and make people aware of the disparities that we are seeing. So the challenges is just really finding the information, and then also having denominators so that we can produce cancer rates and things like that, which is a particular challenge with the sexual orientation and gender identity types of variables. So it makes it a little harder for us to find patterns and know where there are outliers and where there are things that need to be done.
I'll speak on behalf of Linn County Public Health. So one of the branches here at Public Health is our Assessment and Health Promotion branch. And that means we have an epidemiologist as part of the team that helps make sure that we are gathering data, not only comparing our county results to the state, but also on a national basis. There are three things that I think I want to highlight. One is, and at any point, I would encourage you to, if you're in Linn County in particular, just Google Linn County Public Health Reports and Publications, and you can see a whole page worth of various types of reports. So we have reports about our community health assessment and our community health improvement plan that are updated every 3 years. And those are reports where we really zero in on what are the issues that we are going to address collectively and collaboratively as a community with the hospital systems and with the community-based organizations. And those reports do include a fair amount of disaggregation. So it's not just the totals, but looking at things by race and by ethnicity and by gender, and in some cases by LGBTQ orientation. And I'm not going to list the whole list, but that's one set of reports. There's another more specific report that was published in January of 2020, which again kind of helped lead to the creation of my role, and that's racial differences in health outcomes and looking at chronic disease by race and seeing that, yes, there are gaps. And the point of collecting the data is really to be able to get to what is the root cause, so that when we identify the root cause, we can then develop solutions. I'll give a real specific example of how we pursue solutions, and that has to do with vaccine equity. So we're actually partnering with the University of Iowa College of Public Health because we've seen from the data that the incidence of COVID vaccination amongst African American or Black men ages 18 to 35 is lower than the rest of the population. So vaccination rate is lower, but the burden of infection, the incidence of infection of COVID-19 is higher. And we want to find out why. How do we pursue that? By holding focus groups as one example, by doing surveys to be able to understand what is the lived experience and what goes into the thought process that contributes to those results.
Well, congratulations, Anne, on your position. I'm really glad. I'm happy to hear that this is has been created. I think data is critical, especially for our refugee and immigrant community who English might not be their first language, often is not, or they might be pre-literate. And often what we're finding is that we are, as an organization, having to create our own tools and our own methods, in part because you have so many different languages, so many different tribes and sub-ethnic groups. For Burma, which is we were founded by refugees from Burma, you're talking over 12 different languages. So within all our programs, we track demographics, but I think what we really have as a community-based organization are those relationships. We have a constant feedback loop. We know what our community, right? We are the community. So and we would love to be able to tap into some of the work that's being done. It's just, we don't have the time. We don't have the bandwidth to be able to do that. And we would love to be part of it from the concept to the creation. But often we are struggling to meet basic needs for our community. So that would be the priority. But yeah, our work with during COVID, and we had tracked everything from our helpline that we established to people who are coming to our access center. I mean, it's pretty shocking, really. So I think this is a very important topic about how to track and then how to get that data out there, and then how does that data actionable?
One of the things that we paid attention to when collecting data. Well, the first was we worked in partnership with Iowa Health and Human Services and UNI to create a survey that could be accessible to LGBTQ Iowans. One of the things that we really had to pay attention to was that a lot of LGBTQ folks, even if it was an anonymous survey, felt nervous that they would be outing themselves or wouldn't be safe to complete a survey if we were asking about like what county they lived in or what their zip code was, because it is deeply unsafe to be LGBTQ in the state of Iowa, especially in rural areas. So that was one of the things we came across. Additionally, paying attention to, like Henny said, bandwidth as well, and trying to incentivize folks that took our survey for our health needs assessment. And of course, the other thing was that some of the things we asked about, like experiences with sexual assault and things like that, tend to be very triggering. So we really wanted to pay attention to how we took care of folks in that process of completing the survey and sharing their stories as well. But I would say that the main barriers is folks not feeling safe and comfortable to speak from their experience, especially if they are in rural Iowa, and their ability, time, and capacity to speak to that experience as well.
So, Anne, you talked a little bit about the reports that are available from Linn County Public Health, and we know that some of these disparities impact people through all of the components of their lives. And it's so important for other organizations maybe to have a good understanding of some of the needs of these different populations when they're interacting with them. For the group, how does your organization work to inform the community about those disparities that are currently impacting Iowans seeking medical care? What should Iowans and potentially some of these organizations working with people know that hasn't been a big enough part of the conversation?
Yeah, thanks for asking that. I'm going to use what we refer to as the CHA chip again as an example, because it's something that happens on a cyclical basis. And while it is a highly collaborative process in terms of engaging community-based organizations to assess the data and really identify, or I should say, identify and then prioritize opportunities that can be worked on together, we know we still are not reaching the entire population in the development of that. And one of the high priorities for me is to make sure when that report is published on our website and shared in email distributions lists, that we really take another level of connection in the community, and particularly connecting with underrepresented groups. You know, we often talk about amplifying voices of communities of color or communities that are underrepresented, and that's true, and that's important. We also need to co-create solutions, and so it is fully my intention that by familiarizing more in our community with the way the process exists today will prepare us for the next cycle, and how do we enhance the process and how do we engage more so that those solutions are impacting the health outcomes as we intend them to. We also have a network called My Care Community, which is about between 30 to 40 healthcare and social service providers, and it's a connected online referral system. And so the idea is to make sure that, or to make it easier for individuals to get help across the various types of social or human services, to eliminate or prevent double referrals, to really make that more of a seamless effort. So that's a relatively new system. It was just established in 2016, but I tell you, I have colleagues here, one in particular, who is actively recruiting for more participants in that system, because the more providers that are conducting those or helping with those referrals, the better we can serve our community.
I can just chime in that, so in wearing my Iowa Cancer Registry hat, we do put out an annual Cancer in Iowa report each year where we try to feature, highlight a certain population or exposure or type of cancer, and a couple of years ago is when we did the racial ethnic cancer disparities in Iowa. And I think that was really eye-opening for a lot of people. Like I said, to find out that Iowa has been in the top 3 states of all 50 states for the last several years of having the highest Black cancer mortality rate in the country. So that is a persistent issue. Through roles as a researcher with Holden and in Iowa Cancer Consortium, there's a project with some community advocates in Waterloo, Iowa, where we see some of the greatest cancer disparities in the state. Even just contiguous zip codes that all touch each other. The zip code that contains about 30% of Black population has substantially worse health outcomes related to cancer. And so they're all working together for the community members to really identify where they want to put their resources and energy, and how the researchers and with the resources from the Iowa Cancer Consortium can help address some of these barriers, some of these awareness issues. There again, Black males in that area experience the worst death rates from prostate cancer and a whole host of other cancers, and they experience cancer at a much younger age than white populations. So lots of things to dig into there, and a lot of community groups working together, which I think is always really important to just build awareness and get engagement in communities to start addressing some of these disparities.
In regards to how do we raise awareness, because we are a community-led organization, it's our team and our community themselves where we are working to help them tell their own story. So we will see community members in everything from presentations to going to a city council meeting to sharing their story, going to the Capitol, and we have, traditional ways of amplifying, such as blogs and Facebook and everything. But I think because it's the peer-to-peer model, we see that someone from their own community helping them or talking about an issue builds that kind of trust and communication that allows them to share to others. And so I think, and I think the second question you had asked was regards to what we might tell other healthcare providers. The complexity I think everyone's aware of that, but there really does not exist a referral system of any real substantive nature for those who do not speak English. It's really kind of it's not a bridge. I often call it a plank, because when you even something basic like medications. We've had plenty of families who have not received their medication because they don't know that it was sent electronically, or they don't understand the medication they're taking, and they're taking it, orally rather than rectally, for example, right? So I think that it's the assumptions I think there's a lot of assumptions on how we are accessed, and then how we get from here to here, and examining that. You'll see a ton of gaps, and that's why we really need people from the community who have the trust and the language and to build their leadership and ownership. But there is a lack of resources and funding. There is more of a push right now, which is wonderful for DEI and belonging, but that unless that comes with the type of support and resources, we're asking the most marginalized to volunteer and to make time when that's the last thing they have.
I think those are really good points, and I agree. I think that's what we come across. It's actually kind of funny with LGBTQ health and wellness disparities, because I think that's like one of the only things that people know about our community. I feel like a lot of people, there is a rich history of medical pathologizing of sexual orientation and gender identity. In fact, the way that most healthcare providers have talked about us in the past is that we are people that need fixing. And so it is funny to talk about healthcare disparities as well, because I think that that's the first thing that people come across. They think about the mental health care disparities. They think about STD and STI transmission. And we have all of these numbers, right? And our health needs assessment sheds so much light. It's such an important piece of information to share. But I think, one thing I I struggle with is that, like, where do we go from there? Like, what are we doing with that information that's meaningfully changing the game? And how are we reallocating resources, right? It's not enough to talk about it and promote awareness, because in my perspective, in my opinion, people are aware, and that's usually what brings people to the table, that they're interested in that. So what I'm really interested in is how we move money around and really shift our priorities so that they are adequately representing the needs of marginalized individuals. So those are some of the things that I come across, but it is really nice to have more Iowa specific data. I think it never hurts to have more stats that come home to, like, these are folks that are your neighbors living in your communities. And I think that that is the most powerful thing about the health needs assessment that we conducted, is that, you know, it's not nationwide stats. It's not, oh, it could be anyone anywhere. It's like, no, this person in your zip code is having this experience. So I think that's the powerful piece, but I want to see how that can lead to systematic change.
So localizing that experience so that it's not this national problem that can be sort of distanced from. Got it. So to your point, Henny, Iowa has historically been considered this very homogeneous place, but that's been changing over time. At the last census, it was identified that nearly half of Linn County's population growth is due to immigration. How do those shifting demographics play a role in the importance of tracking data related to health? I mean, it's nice to have, we want to be welcoming and inclusive, but where does the rubber really meet the road?
That's a good question. Well, I could say that, for example, with refugees from Burma, they started arriving in 2007. And then when I got involved in maybe 2009, 10 years later, I would go to a hospital and I wouldn't see any languages from Burma on their list of languages. People didn't even know people from Burma and other Nepal and others were here. I mean, and you have many towns that are, especially meat processing towns, that are majority immigrants. And, you know, the refugees that are resettled directly here are maybe 20%. The rest are coming from other states and they don't have any services. And when you're talking about, you know, the nature of migratory patterns, we're not even seeing them. They're not visible. And but if you go to a small town, I mean, I could say for Columbus Junction, for example, which is a town of 1,600, at one point about 600 were Chin from Burma, and that's a specific ethnic group. And without understanding that, I mean, obviously, we're going to see lots and lots of disparities because they're not included. You know, I mean, the census, the report that we have that is in English, I mean, it's skewed for those who can fill it out, you know. So if we do want to really know what's going on, we got to get out into the communities and see. So yeah, I mean, recently, even during COVID, I had asked about the warm line, because we keep getting contacted from organizations doing really great things, saying we have this service. And so I said, you know, I don't think the telephone lines will work for mental health. And so we did ask, and I mean, out of 20,000 contacts in a period, I think this is a period of 10 months, 28 were those whose English was not their first language. Which is really shocking. And I'm thankful that they captured at least the English as a second language. But when we're asking about, you know, all of the services, if you're not disaggregating the data, Asian is like 50 countries, right? For example. I think thinking through that and how, what are we when we're looking at the data and doing an analysis of, is this data reliable? Is this really capturing? How are we trying to capture that information? And that is building relationships with the community and giving them the resources and the dignity and the respect so they are wanting to participate.
Henny's comments remind me, or should remind all of us, and you've said this, it's not, you talked about the plank, so that's certainly a graphic image. And it's not as simple as sending it off to a to get it translated, right? Because it's the language, but it's also levels of literacy that vary. It is cultural differences in terms of how we do healthcare here in this country for those individuals who are moving here from elsewhere. And then certainly the trust piece. I think we are, I'd like to think we are getting smarter about identifying those gaps, but Henny's right, in order to have the quality quantitative data, the relationships have to be there, and so that you're also getting the qualitative language. Qualitative data.
So last week, the U.S. Department of Education announced a $6 million grant to the state of Iowa to advance mental health supports in schools. How do projects designed to expand access through public schools help to address healthcare inequity?
I'll start with that one. In public health, we talk about the social determinants of health, which impact our health outcomes. And it's where you live, where you, your education, your economic stability, your food and transportation. Those are basically the 5 broad categories, and they're all intertwined. And often when we think about health outcomes, we think about, oh, are we going to the doctor? Do we have a primary care physician? And actually the social determinants of health are, some estimate, easily 40% impact in terms of health outcomes. And if you add in the physical environment, it's about 50%. And so the education is a big piece of that. So what happens in the schools has a long-term impact, not only for our kiddos, but also for their families. I'm glad to pause for a minute on mental health in particular, in that since this grant is to address mental health supports. You know, before COVID, the stats that were frequently shared are that 1 in 5 adults will experience a mental illness each year. 1 in 6 youth, ages 6 to 7, will experience a mental health disorder each year. And we all know COVID changed a whole lot for all of us. And sort of the silver lining that at least I like to think of it as a silver lining is, as a result of COVID, people have been talking about mental illness more, about anxiety and depression. And globally, or rather in the US, during the first year of COVID, 4 out of 10 adults in the US reported symptoms of anxiety or depressive disorder. That was up from 1 in 10. So it went from 10% to 40%. And globally, also a 25% increase in the prevalence of anxiety. So those stats that I just shared in terms of what happened since the COVID pandemic was declared apply to adults. But we know, in fact, some of you may have been in an earlier session this morning on mental health and in the schools in particular. So to me, it's an example of treating the whole person and remembering that mental health is health. Last thing that I'll leave with you is children from low income or racial minority populations in the US are less likely to have a conventional source of medical care, and more likely to develop chronic health problems. So addressing issues in the schools is a great place to contribute to this effort.
Any other thoughts on that one?
I would just agree with Anne and saying that, you know, I get a shout out to the teachers, because a lot of our kids, you know, talk to their teachers, or when they're going to school. School can be a safe place, can be. And for often, you know, I mean, for the families, having a day off is really difficult, because the families really don't have that kind of support for childcare. So the kids are often, you know, they're getting fed at school. They they are able to talk to some teachers who will go above and beyond. So it's one place where you can really get more access for the refugee and immigrant kids.
I can only speak sort of personally on this one, since most of my work is around cancer, but during the pandemic, my daughter experienced an eating disorder, and it took every ounce of privilege and connections and healthcare know-how and beating down doors to really get her any care in Iowa. And it was really shocking to me to see the lack of resources we had for an illness like that can be highly deadly. And came to realize too, in terms of data collection, we have no questions right now on the Youth Behavioral Risk Factor Survey to even assess eating disorders in our youth and to even know what the rate of that is in Iowa. So I just think that's a huge, a great investment, and probably needs to be about 3 times more, unfortunately, to even scratch the surface of what I think kids are going through the last couple of years. And just the stark contrast in working in cancer. There are a lot of resources. There always could be more, but I was shocked at the lack of resources in the mental health realm and how few resources there were, even for people with good health insurance and knowledge of the healthcare system. So it was very eye-opening for me, and I'm very glad to see at least it's a move in the right direction.
Absolutely. I always like to shout out Iowa Safe Schools, which works with LGBTQ youth, K through college age, and they do some incredible work in this area. But we do know that schools can be a safe space for LGBTQ youth. It's often where they connect with people that will, if they're a trans or non-binary child, they connect with people that might use their correct name and pronoun, which reduces rates of suicidal ideation by 30%. It's literally life-saving to have a supportive system in your school. But similarly, when you don't find that connection and that support in school, that's also where we see a lot of harm done with LGBTQ students. So that's something that we pay attention to as well. But I think schools can be incredibly powerful in bridging some of these gaps, and school counselors, teachers, and support staff can really make a huge difference.
Now, Max, you've touched on this a little bit already. Switching gears, stigma and discrimination, as well as a lack of access to care, contribute to disparate outcomes for transgender people nationwide and here in Iowa. How is your organization working to acknowledge those challenges? And this question is for the group, and save trans lives. And what should healthcare organizations and workers know?
Yeah, there's so much to say here, but some of the things, I would start with our health needs assessment. Of course, tipping my hat to Malachi Mignon-Sosa, who has done incredible work with our health needs assessment. Knowing the information, knowing the statistics in Iowa is really, really important. And also nationwide stats. The National Center for Transgender Equality puts out a survey every 5 years or so that give us really important information, both state specific and nationally. But some things that I would say is the first thing is that we need to trust trans patients and clients, that they know themselves better than we ever could, and that we want to create more access to healthcare, not less. We find a lot of gatekeeping and barriers in trans access to healthcare, especially in the state of Iowa. And often this is because of rich histories of gatekeeping within the medical community. I think we need to talk about the fact that the average transgender Iowan has to drive an hour and a half to see an inclusive care provider, and that's not even somebody that can prescribe hormones or refer somebody to a surgeon. These are folks that will, do a basic strep throat test with somebody without asking them invasive questions about their genitals, right? So this is really important as well, to make sure that we have more well-trained doctors in rural parts of our state. I have worked at an LGBTQ clinic here in the state and have met people that have had to take off time, 4 or 5 hours of their day just to get care. And then, that's half day off of work or school, mileage, manage a hotel room, all these different things. And so I would say that when we talk about trans disparities in healthcare in our country and in our state, we have to pay attention to folks that are deeply rural, the barriers they face. We also have to pay attention to the fact that trans and non-binary people tend to be lower income. They are disproportionately represented in individuals that are experiencing houselessness, homelessness, or poverty. They often work service industry jobs that do not provide healthcare and are not stable income. And very, very often they face barriers and discrimination in other parts of their lives as well, in addition to losing familial and family systems and support when they come out. So this is a really multifaceted issue. I could talk all day about it, but it's really something that we have to be thinking about, everything from housing discrimination all the way to healthcare. These things all have to work together so that we can bridge some of these gaps.
Any other thoughts from the group? Max nailed it. Okay.
Other
Mary,
than I'll add again, at Linn County Public Health through our clinic, we offer testing and treatment services. And part of the relationship building means that we are particularly for infections that may be more prevalent in the LGBTQ community, or so relationships with, or rather being present at Pride events throughout the year. And that's an important part of, again, just building the relationship and then having the treatment and testing available, testing and treatment, I guess.
so Mary, you've talked a bit about some of the health disparities specific to cancer issues. So you've talked about how those disparities are being tracked a little bit. How long has that work been going on, and have we made any headway?
Yeah, really, the first time we've been tracking racial ethnic data all along, but I don't have any better excuse than to say we weren't honing in on that population, that there are less than 500 Black people per year that show up in our registry. And for some reason, that sort of, I think, lulled lots of us into the sense of it must not be that big of a problem. They're underrepresented in this cancer registry. And what we didn't realize until a couple of years ago is that while they may be in there less, it's because they're dying of everything more. They don't even a lot of Black people don't live long enough to get cancer, but sadly, when they get cancer, they get it at younger ages than white people, which was something that was not recognized, at least in our state, until recently. So we have, in every major type of cancer that we have in Iowa, they have a higher mortality rate. There are cancers like breast cancer where Black females have a lower incidence rate or a lower rate of new cases, but still have a higher rate of death from breast cancer. So almost anything we look at, they're at a disadvantage in terms of early detection, timely treatment, and guideline concordant treatment and good outcomes. And so the last couple of years, we've launched a lot of studies specifically to try and figure out what are some of the causes and what are some of the things that we can do to address that. But we have a really long way to go, I think. And fortunately, a lot of the organizations represented here today and the Iowa Cancer Consortium recognized long ago, even without the data, that obviously there are a lot of health equity problems in Iowa, but I think it was kind of a stark wake-up call to a lot of at least researchers. You always think the South is worse at everything than the Midwest. You know, we usually do pretty well here, but we are worse than the South. We have higher Black cancer mortality rates in Iowa, Nebraska, Illinois, Wisconsin than they do in the South. And that to me was a big wake-up call. And I think because of the small number at any given time of Black people with cancer in Iowa, I think there's just the support systems are not there. There are not doctors that look like them. There are not nurses that look like them. There is only one cancer support group I've come in contact with in the state that's specifically for Black populations, which is the Splash of Color group in Waterloo. there are not a lot of support groups. There's not a lot of people around who they can share experiences with, get advice from, things like that. So I think we have to do a lot more here, and that's just the Black population. That's not to get into all the other populations that we've been talking about here today, but just as an example, that's something we have been tracking and still have such a long way to go to address. But at least we are starting and really trying to, as the other speakers have talked about, build those relationships, because it's just impossible to address these disparities and really figure out how to meaningfully address them and eliminate them without the engagement of the people most impacted and who are living it every day.
Thank you. I'm going to check our chat and see what questions we have from the audience. I've seen several chats coming through. All right. Can you all tell us how you are engaging in the community health worker model that is growing across the state? This seems to be showing some promise in employing lay people from many communities and providing better health outcomes.
I can speak to this. I love this question because I'm a community health worker, so big fan. I have seen, even in just my role, working as a community health worker in LGBTQ health settings, how meaningful that can be. And by that, I mean, just like a personal story, sometimes when I am in a healthcare space as a community health worker, I will be providing wraparound services, right? So, you know, do you have mental health care, you know, after they come in for a variety of different care? Do you have mental health care? Do you need a support group? Do you need community groups? Do you know where your local pride is? Those things. But what always gets me is when I walk into a room with a trans or non-binary person, and I walk in and I'm the first trans or non-binary person they've seen in a healthcare setting. And just the way that the room changes is so wild. And a lot of the folks that I have gotten to work with are younger. And it might be the first other trans or non-binary person they've met. And that's the power of having members of the community be community health workers and work within that model, because you see yourself represented in those folks. You have that shared perspective and experience, and it can be really, really powerful and very empowering to feel that you're really in community with someone, and to break down the idea that healthcare is, you know, I give to you health and wellness, and rather that we are as community cultivating that together. So big fan of the community health model personally, and I've seen, you know, a huge change and difference just in the work that I've gotten to do in a very micro setting, right? So I'm very excited that I've gotten to work with a lot of other community health workers that are doing the work out here in different communities as well.
At Linn County Public Health, we currently have one individual who officially functions in that capacity. And so we've seen the benefits of that. And I'm also aware from a health equity standpoint that expanding the number of community healthcare workers community health workers, sort of one of the tools in the toolkit, so to speak. I visited Black Hawk County Health Department last month, and to get sort of a firsthand look at how they are structuring their work overall, how they're pursuing health equity, and how they're building relationships with community-based organizations, and part of their recipe does include community health workers.
Yeah, that's I'm glad you brought up community health workers, because I think that is what that's the model that EMBARC uses. We call it Navigator. And I think, I mean, a peer-to-peer train the trainer. And what makes it really unique and important is that when you're talking about different languages and different intersectionalities, when our navigator goes out to the community, they're going to be, you know, meeting people truly where they're at. So if there is, if one person takes 5 times before they understand and can do something on their own, it'll take 5 times, you know. And I think for our community, it's you know, a lot of moms who don't speak English. So I think, you know, I love that people are highlighting community health worker as a legitimate model. I would just say that, you know, while we try to create that legitimacy and understanding to allow for that flexibility, because community health workers in that model can be very different depending on the community. But it's critical to what we do, because there is no one else in the community who can do this work except the community themselves.
Yeah, it's definitely a model that the Iowa Cancer Consortium is just starting to use now, and do have a community health worker in Waterloo, and then another one that's more on a rural community basis. And I would love to see that grow for all the reasons that everybody just described. I think that's just the best way to get engagement, really understand what's happening in the community and what are their needs, rather than sort of imposing what we think their needs are onto them and sort of missing the mark with our efforts.
So another one from the chat. What data are not currently available that are needed to inform this conversation? Any comments on how the field of public health can improve on data collection and dissemination? I've noted a few: localized data, building relationships to allow capturing quality data, disaggregating data by subpopulations. What else?
I would add probably community participatory models of conducting data. Right now, we're working with the Harkin Institute at Drake University with our community members from Burma to do a community participatory focus group that they are leading on social service systems. And so the more we can provide the resources to train and support community members to be part of this process of again, from beginning to end, the better data we're going to receive, and on an ongoing basis, I think.
And there's an active effort underway to be more effective in how we share data with different entities, and so that we're not duplicating efforts by everybody collecting the, I mean, I think the beginning part of the question was, what data are we missing? That's could be a very long list. When not just the topics, but when you start to think about what are ways that we need to disaggregate, because we really aren't digging deep enough.
Yeah.
All right. Sorry, go ahead.
Oh, I was just gonna say, it's hard, the behavioral risk factor surveillance survey and things like that. They do a great job at sort of estimating overall what's happening in the state, but just like everybody here has described, it takes more than that. I mean, that's just sort of on the surface, and it's super informative and very helpful, and we need that as a sort of guiding data source. But really, to have relevant community level data to be able to really take the action to where the community is, it has to be more. There has to be more people that are surveyed or interviewed. It just has to be broader than it is now. But that takes a lot of resources and investment for sure. So I definitely think we need to keep going that way. Otherwise, it becomes hard when you don't have data to drive the decisions as to where you'll get the biggest impact for certain interventions.
I would also just add that, I mean, I think talking to the community members or getting a focus group of what data we're collecting and why people don't want to participate in surveys and focus groups is really important. If we ask the community members, what are the issues that you're facing? And then how can we find solutions? I think we'll find that they would be willing to participate. But I see a lot of community members that even, that are tired of filling out surveys or filling out forms of which they don't understand, and they don't know, why, except to be studied.
So in our last 5 minutes here, I'd love to know from all of you, what projects or efforts have you seen recently that you're excited about? And this could be from anywhere in the world or completely hyper-local to your own organization or ideas.
Well, I will start. And thanks for the offer anywhere in the world, but I'm going to say there's no place like home, and I'm going to stay local. And I've brought up the CHA-CHIP, the Community Health Assessment and Community Health Improvement Plan, several times already today. It's kind of important. Every local health department in the country is required to complete that process. And guess what? It is in order for that to become more effective, the broader community needs to see, how does the process work today, and help us co-create how does it work better in the future. So we have some ideas. And again, I've already talked about not just amplifying voices, but co-creating solutions. You can go to the Iowa Department of Health and Human Services site and click on any county and see their community health improvement plan, or see their annual update to their CHA-CHIP. So I would encourage folks to do that. And I just am excited for what that means for us in Linn County in terms of connecting the area. A piece of the CHA-CHIP for us is the newly convened Alliance for Equitable Housing. And there's a group that an entity that stands up when we have a disaster in the area. So the Linn Area Partners, let's see, I'm forgetting all the letters, but LAPAID is what it stands for. So we have had opportunities with COVID and with the derecho to stand up that entity and see what the needs are. And housing, not only in that process, but in other community impact assessments that have been done, whether it's through the United Way of East Central Iowa or collaboration between the city of Cedar Rapids and the county of Linn, identify housing as a critical need. And so this newly convened group, the Alliance for Equitable Housing, is about, again, how do we come together and identify and prioritize solutions that we can work on collaboratively across sectors, and not in place of individual priorities of organizations, but something that will make a big impact across the board. And I have to tell you, something that's interesting about that group, focus groups that were conducted over about a year period with all sorts of community-based organizations, grassroots organizations, you name it. The topic of redlining and housing discrimination came up in nearly every conversation. And maybe there's been some extra attention to that because the African American Museum of Iowa just concluded an exhibit on redlining. But what this group is focused on in one of the work groups is, how do we address the historical impacts of redlining that was legal and in place from the late 30s into the mid 60s, as well as current systems and current practices that perpetuate discrimination and inequities in housing. So if I had a dime for every time one of us used the word new today, I might be able to go buy lunch or at least a fancy coffee. But there is a need for some new effort and new partnerships and new collaborations. And so I am very excited about what's underway here.
I'm excited about a new initiative that we're working with the Iowa Coalition on Domestic Violence in creating a health equity campaign and a refugee and immigrant voices in action, really to intentionally build solidarity with other immigrant-led groups, to build leadership, to build community and advocacy around that. Working towards systems change, we really don't have people or organizations that are led by the people of immigrant heritage. Outside of Iowa, I look at Rooted Vibrant Communities in Seattle. They have a social justice league, which they just started, which pulls together funds from with 40 plus BIPOC partners. So it's trying to do funds and fundraising and development in a different way. So it's more sustainable. And I mean, really trying to create a more equitable funding sector is critical, and thinking about that. So yeah, I would bring up those two.
I would just bring up again the steering group I talked about in Waterloo. The community members are doing amazing things. Speaking of redlining that Anne brought up, Waterloo remains one of the most segregated cities in all of America, also due to the really extreme redlining measures there. And this group of people have just come together to really decide what is really important to work on in their community. They're an amazing model. I think they'd be a great model for any other city in Iowa and even other populations, the way that they're able to help steer efforts and work with us both at the university and the Iowa Cancer Consortium, and use all the resources and use all their talents and relationships to really move forward. And it's been amazing to watch.
All right, we are at time. I want to thank all of you for joining us today. I want to thank all of our panelists. Again, our panelists are people local here doing the work. So I know there are more questions. Please feel free to communicate with the organizations in our communities that are doing this work. Thank you again for joining us today, and have a wonderful rest of your conference.
Thank you.